welcome everybody to this launch event for our second annual report from the National Child Mortality Database. We're really pleased to be able to present this to you today and showcase the first annual report from Ncmd that includes data. Some of you might remember that previously we published our first annual report, but that was a sort of development report. So this is the first one to include data. The format of the session today is that Karen's going to do a presentation, but we don't have a question and answer session. So some of you who attend our other webinars might be used to there being an opportunity for questions and answers, but that's not the format of this launch event today. So, but if you do have any comments about the report or questions or anything you'd like to let us know, then you can pop it in the chat whilst Karen's presenting, and we'll pick anything up afterwards that needs responding to. So without further ado, if I hand over to Karen to start her presentation.
Thank you very much, Vicky, for the introduction, and welcome everybody. For the next half an hour, I'll be taking you through the second annual report of the Ncmd. So the National Child Mortality Database is commissioned by HCUP on behalf of NHS England. The program's led by the University of Bristol in partnership with a few partners. And we have three charities, partner charities, who are part of our project team: Lullaby Trust SANS and Child Bereavement UK. And the database started collecting data on the 1st of April 2019. And it's this first year's data that I'll be presenting today. So as you probably all know, the aim of the Ncmd program is to collate and analyse information nationally, so that's England, to ensure that all deaths are learned from and that learning is widely shared and that actions are taken locally and nationally to reduce the number of children who die. All the professionals on this call involved with looking after children will know about the child death reviews in England, which are performed by statute. And the child death overview panels, 58 of them around the country, are tasked with reviewing deaths of children residents in their area. And by statute, there's a legal requirement to notify all deaths to the Ncmd within 48 hours. And following this notification, there's a comprehensive multi-agency information gathering process, and ultimately ends in the child mortality review meeting locally, and then the review by the CDOP, using statutory forms and a structured way of collecting this data. And that's the data that we analyse in the Ncmd. So we look at data in two ways. One is the notification data coming in within 48 hours. That's a way of doing a virtually real-time mortality monitoring. And then also we look at the complete data when a child death has been completely reviewed by the CDOP and completed. And of course, that's a very rich resource for looking at different factors, particularly the modifiable factors, which you'll hear about a bit later. So this report, as Vicky said, is the first report where we're actually presenting data. It was published on the 10th of June. You can find it on our website. Go and have a look there. It's free. It's free to download, and it covers the deaths of children between the 1st of April 2019 and end of March 2020, so pre-pandemic, and also covers a second cohort of children who were reviewed during that period. So some of those children died before April 2019. In this report, we also cover in the first section some of the outputs that we've produced during the pandemic. So this is an important one that if you've not read it, go and have a look on our website. This was the child suicide rates during the COVID-19 pandemic. This comes directly out of the data that the system that we've developed to do real-time surveillance. And many of you on the call today on the webinar today will have contributed data to this. This has been a tremendous success during the pandemic due to everybody's hard work out there, reviewing child deaths, making sure the data is complete, and of course the NCMD team working very hard to analyze these data as they come in. The other output that was a big success, and this has actually been published today, it's open access in ADC, and the links here. This looks at child mortality in the pandemic, also using the real-time surveillance system that the NCMD set up, also with the help of every single one of you reviewing child deaths and entering data and notifying us within 48 hours of every child death. So real-time, complete population level child mortality for the pandemic. So go and have a look at that. You can download it as a PDF. So the key findings from the first report, our second annual report on deaths that have occurred between 1 April 2019 and 31st of March 2020, there were 3,347 child deaths up to the 18th birthday, which equates to approximately 28 child deaths for every 100,000 children living in England. 63% were infants, so under a year of age, and 42% were under 28 days of age, so neonatal deaths. And the infant mortality rate for this period was 3.4 per 1,000 live births. 78% of deaths had ethnicity recorded, so there's still a proportion where we need to improve this reporting. 62% were from a white ethnic group, 19% from Asian or Asian British background, 9% from Black or Black British background, and 7% from a mixed ethnic background. There were approximately 3 times as many deaths for children who were resident in the most deprived neighbourhoods in England compared to the least deprived neighbourhoods, so a big social gradient. And where we had access to gestational age birth recording for infants below 1 year who died, 69% were born preterm, so a big contribution of prematurity. And where we had place of birth recorded, 78% of deaths occurred within a hospital trust. So the majority of children die in hospitals, 22% occurred outside hospitals. If we look at the child deaths reviewed between 1 April 19 and March 2020, there were 2,738 child deaths reviewed, reviews completed. The category perinatal neonatal event was recorded for the largest proportion. This is typical, we've seen this over the years, 31%. And where sufficient information was available for this group, 33% had modifiable factors. And of all deaths categorized as perinatal neonatal events, 77% were prematurity related, which means that prematurity accounts for almost a quarter of all child deaths reviewed in England. And that goes all the way up to the 18th birthday, so a large contribution of prematurity. And if we look at modifiable factors, the highest proportion of reviews with modifiable factors were sudden unexplained deaths and deliberately inflicted injury, trauma and suicide. And malignancy, so deaths caused by malignancy or cancers, had the lowest proportion of reviews that identified modifiable factors. So if we look at child death rates per 100,000 population, this gives you the different regions with confidence intervals, 95% confidence intervals for England. Now, it's important to note we have not done statistical tests on this to look at differences because there was a small proportion of missing data. So there were, I think, 3 CDOCs that did not completely submit all their cases. So going forwards, if everyone submits their cases completely, we will be able to actually measure these, look at the comparisons here. So at the moment, we can't really comment on whether there are any regions that are particularly higher or lower. And then if we look at infant mortality rates, similarly across the country for different regions. Again, we've not done statistical tests here to show, trying to see whether there are actual differences because of a small number of incomplete cases. And of course, going forwards, if we have 2-3 years worth of data, then confidence intervals will narrow and we'll actually be able to say whether there are true differences between regions. Now, if we look at the number of notifications by age and sex, what you will see is at the top here, we've got the number of cases, so 0 to 800, and in green, females, blue, males, and then the age categories on the left here. You will see that neonatal deaths, biggest proportion, and then that decreases over the age groups, and then there's a slight increase again at 15 to 17. Males are overrepresented in every age group. That is a very typical finding. Boys are more likely to die of all causes up to the age of 18. This is the distribution of ethnicity, which I've already covered in the first few slides. And it's difficult to comment whether these proportions are the same as the population distribution of ethnic groups, because we're working with old census data. You may know that the census has just been repeated this year, but also ethnic data is not complete for in our database. It's more complete than any other mortality database, including ONS, but we can still improve on this. So this is really a call for all of you out there. When you're reporting, please make sure that we have an accurate ethnic group recorded for every child. And also GP practices, this is very important. If families haven't reported their ethnic group, of course, people can opt out, but it's really important that we try and capture this because there may be some very important lessons here. And this looks at the social gradient of mortality. So looking at the index of deprivation. And what you can see here is the most deprived areas in England had more deaths than the least deprived, and there's this distinct social gradient. You may know that we've done a report on this, on the exact same cohort of children. That was published in May. Go and have a look at that. It looks at this in a lot more detail, but we clearly have a problem in England with the social gradient. Now, looking at the number of notifications received by CDOPS by place of death, as I've said already, the majority of child deaths are in hospital, 78%, and the biggest group here are on neonatal units. So 25% of all deaths are on neonatal units, followed by PICU, 16%, and etc. As you can see there. 4% of deaths occur in hospices and 13% at home. And then other areas, some small percentages there. Now, for the first time ever, we have looked at the data, looked at gestational data across all age groups. So the gestation that the child was born at. And also we've looked at that, but in those under 1, where the data is far more complete. This is also a plea to try and include, gestation, irrespective of the child's age when they die, because this is really important information. It's also something which is not very well collected by the NHS. We're good at when children die in the neonatal period collecting this, but beyond that period, we're not very good at this. So it's something we do need to look at improving. Now, looking at the gestational spread here, you will notice that there are babies who die in the gestations that we call pre-viable gestation, so before 22 weeks gestation. That is because for by law, we collect data on all live births. So some babies born at low gestations are born with signs of life, and then they are in the database. The green shows you the neonatal deaths, 0 to 27 days, and the blue striped bars show you the children that have died post-neonatal deaths, so 28 days to 364 days. What's interesting, you will see here, is the group 22 to 23 week gestation. You can see that some of these babies are starting to contribute to post-neonatal mortality rates, meaning that they are being resuscitated, provided intensive care, and then dying either in the neonatal period or in the post-neonatal period. And you can see that there's two peaks really, 22, 23 weeks, and then again around the term gestation point. Looking at this broken down by different gestational groupings. So less than 22 is the pre-viable group. You can see that that contributes about 10% to infant mortality in our country. The extreme preterm group, 22 to 24 weeks, contributing about 15% or 15% of infant mortality. And then the next group, 24 to 28 weeks, also about 20% contribution. And the late preterm, 25% contribution to infant mortality, and term infants, 30% contribution to infant mortality. So really, it's the first time we've looked at this data in this way, and I think it's quite interesting. It shows you that when you start looking at infant mortality, you cannot ignore prematurity, and you know, that is probably where we can make some of the biggest gains in terms of reducing our infant mortality rate. Looking at where we can modify outcomes after preterm birth, or indeed how we can prevent preterm birth. So looking at the number of reviews completed by CDOP, so these are children that some have died before April 2019, and this gives you a very good overview of the categories of cause of death and the numbers. And if we go through them, that's first category, deliberate inflicted injury, abuse or neglect, then suicide or deliberate self-inflicted harm, trauma or other external factors, malignancy, acute medical or surgical conditions, chronic medical conditions, chromosomal, genetic and congenital anomalies, perinatal neonatal events, infection, and sudden, unexpected, unexplained death. And you can see the biggest contribution here is perinatal neonatal events. And in green, we can see the proportion of these deaths that had modifiable factors identified by CDOPS. So you can see the two biggest categories of death are perinatal neonatal and chromosomal, followed by sudden unexpected death and then malignancy, and then acute medical or surgical conditions, infections. And you can see that the biggest number of modifiable factors are in perinatal neonatal events, followed by sudden unexpected death in childhood, infancy and childhood. The biggest proportion in a category of modifiable factors are in the SUDEX. So this gives you an idea if we have to start making an impact, you know, where if we focus, we can potentially make a very big difference, I reckon, in terms of child mortality in our country. Now, looking at the more detail, these categories of death, and then the numbers and percentage that they contribute. This is a very complicated table, and I think it's probably worth you going through it in the report. But I think the interesting things to pull out here is if we look at deliberate inflicted injury, abuse, or neglect, this gives you the biggest, the total percentage in terms of contribution to all child mortality reviews, 2%, suicide, 4%, trauma, 4%, and you can see that the biggest group there are road traffic accidents. Malignancy contributes 8% to all child deaths reviewed, and acute medical surgical conditions 6%. And here you can see epilepsy, asthma, diabetes, and how they contributed. Chronic medical conditions 5%, chromosomal and genetic 25%, perinatal, neonatal 31%, of which I'll break this down for you later in the slide. Infection 6%, and sudden unexpected unexplained deaths 8%. Breaking down the perinatal neonatal cause category, this has never been done before, and we are now asking CDOPS to do this for us as well, because this is the biggest category in terms of numbers. What we can see is out of the 819 deaths categorized as perinatal neonatal, the 723, so 88% were preterm, below 37 weeks gestation. The biggest contribution was by immaturity or prematurity related conditions. That was 80% in this category. Perinatal asphyxia, 105 babies, 13%, and perinatally acquired infection, 5%. So what this means is that of all the deaths categorized as perinatal neonatal events, 77% were prematurity related. And that means prematurity accounted for almost a quarter of all child deaths reviewed. So a massive contribution there to child mortality in our country. These bars show you, I'll talk you through them, that these show you the different age categories again, 0 to 18 years or 18th birthday, and they're color coded. So we've combined some of the causes of death categories here. So the light green that you can see in the first neonatal period, that is perinatal neonatal events. Biggest 80% of this is prematurity. And what you will see is this light green area gets smaller as we go along with the age groups, but still contributes significantly, for the infant mortality category, so up to a year of age, and then it reduces. The blue blue grid there, light blue, second biggest cause of neonatal mortality, chromosomal and congenital conditions. You can see that actually contributes a large proportion of infant mortality as well. And if you go across the other age groups, it continues to contribute right through up to the age of up to the 18th birthday. The mid-blue grid is the sudden unexpected deaths. You can see in the neonatal period, that's quite small, sorry. But then in the infant mortality bracket, you can see that is the biggest, is quite a significant contributor. And then it reduces again as children get older. And then the green area is dark green or mid-green, the acquired natural causes. So in here we include infection, malignancy, acute and chronic medical conditions, and surgical conditions. And you can see that actually increases quite dramatically as the age brackets increase. And it's the biggest cause of mortality in the actually the 1 to 10-year-olds. In the mid-blue grid pattern, you can see the external factors. So here we've included trauma, inflicted injury and abuse, suicide as well. And we can see that is a very, very small contribution in the neonatal period, but then it increases, and it's the biggest cause of death in the 15 to 17-year-old group. So I think this graph gives you a very good overview of what actually causes children to die in England. Now, CDOPS classify all their child death reviews according to modifiable factors, modifiability, and it's done in the 4 domains. So characteristics of the child, social environment, physical environment, and service provision. And this just looks at the number of death reviews in that year with modifiable factors in each of these domains. And what you can see is social environment is by far the biggest one, followed by service provision, physical environment, and then characteristics of the child. Looking at this in a bit more detail, here we have in the 4 domains, you can see the number of cases with factors, contributory factors in these domains that are modifiable, and some examples. So I'll pull some of these out. So factors relating to the child, for instance, substance misuse or risk-taking behavior. Social environment, this is covered in detail in our deprivation report, so go and have a look at that. But the sort of things that have come out, substance alcohol misuse by parents or carer, mental health problems in parent or carer, consanguinity, parental smoking. And in the physical environment, we have a very big one is unsafe sleeping arrangements. This is still happening all around our country. And causing sudden unexpected deaths in infants. Unsuitable housing, big factor. This includes overcrowding in houses, etc. Lack of safety equipment when cycling, driving in excess of speed limits, big factor in road traffic accidents. And then service provision. Important to point out, this includes all services. It's not just health. So it's health, social care, education, etc. And the big ones here were failure to follow guidelines or pathways or policies, lack of access to appropriate services or not supporting families to access services, poor communication and information sharing between professionals. And this is across primary care, secondary care, social care, between regions, between hospitals, between health professionals and families. So this is an area that we do need to focus on. And then for the first time ever, we have actually looked at all of these modifiable factors, which was a massive job for the Ncmd team. And we've ranked them here simply by most commonly occurring modifiable factors. So this starts to give you an idea about where we can start focusing our energy to make differences. So a modifiable factor is something, if you can modify it at either regional or national level, that you could potentially reduce future child deaths. And the big one that came out really was smoking in the parent or carer. So have a look at the report. There's a whole section on how these factors potentially contribute to child death. But this is a very big factor in neonatal mortality and in sudden unexpected deaths in infancy. So, increased risk of prematurity, increased risk of babies dying suddenly if their parents smoke, and they're exposed to secondhand smoke, also smoke, in parents' clothes and so on. This is something we can change. There is a massive move in the NHS and in public health, indeed, to reduce smoking, the smoke-free program. It's not funded adequately everywhere, so I think this is where we can put our efforts and start pushing to get more services funded to get parents and families smoke-free, and indeed teenagers as well. Second big one, quality of service delivery. This is a big category, and it's a difficult one to unpick. But that is something that I think, particularly when we do child mortality reviews, we need to be very specific what we think the intervention should be. And going forwards, I think we can improve this data so we can learn more and try and pull it together into themes. Third biggest one, unsafe sleeping arrangements. This is still a massive problem. The Lullaby Trust has very good information on this on their website. This is extremely important in the pandemic as well, where there's been less face-to-face contact with families. So when newborn babies are going home, that's the point where we all need to be giving the right messages about how babies should be sleeping at home. Fourth, substance and alcohol misuse in a parental carer. This is a big factor in neonatal mortality, prematurity, as well as sudden unexpected death in infancy. And this is something clearly that we could help with. Maternal obesity during pregnancy. So this is a massive public health problem at the moment, and it's only increasing. You know, we can see on neonatal units how many more babies are being admitted to mothers with gestation, diabetes, you know, during gestation. This is not going to go away, and it's going to need a serious public health effort, and when we could save lives. So, for instance, if a mother has a very high BMI, it becomes extremely difficult to do antenatal scanning. So, to try and pick up congenital anomalies or how the fetus is growing becomes very, very complicated. Also, more complications with birth, for instance. So this is it's very definitely a factor that we need to consider, and we need to work on this. Sixth biggest one was challenges with access to services. Now this is twofold, and you can read about it in the report. But basically, the first is where there are inadequate services, and the sort of things we see is a lack of particularly neonatal intensive care beds. So babies having to be moved around long distances, and also access to potentially sometimes to PICU beds. The second aspect is where families have not been, so hard to reach families, marginalized families, have not been adequately supported to access services. So this is an area where it doesn't just concern health. We need to be working on a much more joined up service provision for especially hard to reach families. Seventh biggest category, poor communication, information sharing. Clearly, this is something we could all do better. Read the report to look at examples. Eighth biggest one, domestic abuse. This is not necessarily where children have been harmed as part of the physical trauma and domestic abuse, but where children have been party to domestic abuse, witnessed domestic abuse. Ninth biggest one, poor home environments, and this is something that came out very strongly in the qualitative analysis of our deprivation report. Housing is a massive problem. For instance, overcrowding, where families, live in homes with 1 or 2 rooms, 6 or 8 people living there, meaning that parents, that there isn't actually a bed for every person in the house. For instance, parents then sleeping on sofas because there are no beds, and then there are extremely unsafe sleeping arrangements for babies. We know that if people adults sleep on a sofa with a newborn baby, or with an infant actually, the risk of sudden unexpected death goes up 30-40-fold. So this is something that actually, we all need to be looking at. It will require major drive between social care, health, etc., to improve this, but it's something that can be done. The 10th category is consanguinity, where parents are close blood relatives. Now, this is something that we need to improve data collection on. We have simply coded this where the CDOC has said this is a modifiable factor, but clearly in some pregnancies, this might not be a modifiable factor. This relates to if families have not had access to genetic counseling, for instance, and they've not been supported to make their decisions about their baby and their pregnancy and about future pregnancies. So this is an area where we need to work on getting better data. I think this might be overestimated in this report. We don't know. And then the 11th one, mental health in a parent carer. This is just going to get worse during the pandemic, and it's something that we're all aware of, and that this will need attention. Section 6 in the report is worth reading. I mean, I think this is a very uplifting part of the report. several examples, anonymized case vignettes of where children and families have had exceptional care during end of life and also during bereavement support afterwards. It sets out what we can achieve if this is all done to this standard. And going forwards, we want to encourage people to. It takes time to write about this. We tend to focus always on where we can do better, but to give examples of where families have really been supported, very impressively, and the feedback's been excellent, means we can all learn from this, and it gives us role models to look up to going forwards. So the final slide, the recommendations from this report, just summarized here. We're asking every CDOP and every child death notifier to continue using the case alert functionality in the notification system, because this actually helps us to review some of these deaths in a timely way. And if there's something that needs immediate national action or learning, it means we can process it very quickly. We look at these every week, in fact, every day. So if something comes out here that we need to actually escalate very quickly to NHS England, we can do it. So the sort of things I can think about that we see is the blind cord strangulations and so on, and any new emerging causes of death, as this is where we will pick it up. We've also said that we need to consider creating and implementing and maintaining a system for structured and sustainable training of all child death review professionals and CDOPs to help us standardize these processes of review more, and that will only improve our data further. And I think going forwards, to really make a difference in terms of looking at modifiable factors and how we address these, this is going to be extremely important, that we all do structured reviews in the same way. We've also recommended to integrate local learning and actions with information from this national report to reduce the number of preterm births and to improve outcomes after unavoidable preterm delivery. This is a massive group of deaths, contributing very significantly to our child mortality up to the age of 18 in England. And we know from a lot of the optimization work now being done, described very well in the BAPN toolkit, how to do it, that there are evidence-based interventions where we can improve the outcome after preterm birth. We can reduce mortality quite massively with some of these interventions. And I think this needs very, very serious effort, and it needs organization and it needs funding. And the review of the most frequent modifiable factors as presented in this report should be looked at by all, and we need to consider how we can address them at local, regional and national level, because these will vary depending on the type of a region you're in, and levels of creation, etc. So that's the end of the recommendation. This page just shows you how you can find out more and how you can connect with Ncmd. So please follow us on Twitter. All the latest news is always pushed out on Twitter. Visit our website, which is very informative. You can read our report there as well. You can also sign up to our newsletters to find out the latest of what's going on in terms of child mortality. There's a whole section for families, information for families as well. And read all, go and have a look at the report sections, the publication section, where we've started to, we file away all the different reports in PDF format for you to read. So I think that leaves us, the only thing to say is to thank all the partners in the Ncmd. And that includes UCL partners, Oxford University, QES, our software company, SANS, Lullaby Trust, Child Bereavement UK, and the programs led by the University of Bristol. And also to thank every single professional who has contributed to child mortality review, and also to notifying child mortality to us within the 48 hours, which has made a massive difference to information gathering in the pandemic. Thank you, everybody.